Guys, have you all signed in for to get CPD? People who need to get CPD, are you signed in? Okay, all right.
shadows, and you are searching for a light that shows you where to go. You'll be on your own, never alone. Nobody listen to your heart. You are taking your first step. All you angels, they're there to guide you through. From now on, just be true to yourself and the things that come your way. From now on, just be true to yourself. Don't be hesitating. From now on, just be true to yourself and the things that come your way. From now on, just be true to yourself. Don't be hesitating. Live in the magic moment. It's time to go on. It's time to go Live in the magic moment. Yeah, yeah, yeah. Live in the magic moment.
Good evening, everybody. On behalf of what was the North Vaal branch of the Chiropractic Association, is now called the Gauteng branch of the Chiropractic Association of South Africa. And we do welcome you tonight, and we thank you for your support tonight. Before we start proceedings, if anybody needs to use the small room in the house. It's straight across, first right, and then straight across the hallway. I'd like to say a big thank you to our local branch committee members. Without you guys, this is an impossibility. So, Melissa Ruthven, where are you sitting? There we go. Thank you for your help. Chase McWilliam, Glenn Payton, Lisa Dickerson, Zelda Barker, I can't see you guys. Thanks very much for your meetings and your input. And a big thank you tonight to our sponsors. As you all can see, Nedbank Small Business Banking are our title sponsors for both Northval or Gauteng as well as CASA. And I'll elaborate on the Congress later after our speaker. But they really are going out on a limb for us, and we are appreciative of it, of the sponsorship. Sadiqa, I don't know if she's here, Sadiqa Rhyme, she's been very helpful, and due to commitments in private practice, she's agreed to after-hours calls, and her guidance is appreciated. Lynn Cormack as well. She's for Lynn and Associates. She's my right-hand lady. She's a conference coordinator, and she's also come here tonight to also help us run things. And then AV and Beyond, thank you for your help. We are not only are we here tonight, but we are actually live streaming right now on YouTube. So we are wanting to take our meetings to everybody in the country. So this is a first, so please bear with us. That is being recorded as well. So people who missed it can certainly get to watch it again, and will also qualify for some CPD points. And I think this is the way of the future with regards to meetings and conferences. And then we'd also like to say a big thank you to High Tech Therapy for your sponsorship tonight. And we've, for many, many years, have had you guys on board, and we thank you for always believing in our profession. And we certainly do have a good synergy between the two of us. So without any further ado, it is my pleasure tonight to welcome our guest speaker. He's been a mentor for all of us, and a friend to our profession, at times a critic, but a mentor and a man who's at times mechanistic in his approach to neurosurgery. But also is a man who understands the power of the mind, body, and soul. And in the healthcare profession, I think this is a necessity to encourage good health. So Dr. Ian Weinberg graduated with an MB-BCH in 1978. In 1986, he was awarded the fellowship in neurosurgery. Between 1986 and 1987, Ian was a military surgeon based at one military hospital. He commenced private practice in 1988 and continues to practice to the present time. In 1992, he pioneered the application of psychoneuroimmunology, which is the study of the influences of mind states on immunity. He subsequently integrated neuroscience with P&I and developed a wellness performance integrated leadership application for the clinical and corporate environments. The application was subsequently quantified by means of an online diagnostic and validated through 3 master's degrees. Between 2001 and 2003, Ian co-developed the Centurion Kineflex prosthetic spinal disc. This was subsequently FDA approved, and the patent sold to the United States. Ian continues to innovate in the microspinal sphere, as well as continuing the P&I applications in the clinical and corporate spaces. The online diagnostic is used worldwide. Recently, Ian launched his book, Leadership with Conscious Awareness, a narrative of personal insights. I recently had the honor and privilege of reading this book. Guys, I encourage all of you to indulge yourself. Like I said, mind, body, soul stuff. There are neuroscience, neuroanatomy that helps you understand brain physiology. There are names like the amygdala, the dreaded amygdala, the nucleus accumbens, which most of us need to strive for, the dopamine, oxytocin. Another word that really comes to mind is neuroplasticity, which is Ian's going to elaborate on tonight. And a personal story, which is, he puts on his neurosurgery face and you think he's quite serious, but he loves to laugh. And he's certainly got a sense of humor. And there's some things in this book that really get you laughing. The thing that stands out the most, I don't want to give too much away, but I never knew you were a pilot. And he had some kamikaze times that he's lucky to be sitting here tonight. So, Ian, I welcome you tonight, and thank you very much for being here.
I'm just going to unpack. I don't usually actually prepare anything, but the brief was so broad that I thought I'd better just put down some stuff, because otherwise I'm going to forget whole sections. I must say, I was looking at some of the... Is that really me? I used to be a ravishing brunette. When I grow up, I want to be a chiropractor. It's always a great pleasure being here. There's always a great vibe. I think probably the most inspiring area of healthcare at the moment, because when I speak to our guys, really you have to take an antidepressant. Things are not very inspiring. So it's a great pleasure being here tonight. Hopefully we'll make it worth your while. So initially, I'm going to just discuss aspects of this book, and since Mike has mentioned it, I'm going to just add to it and clarify it, because it has relevance in the other things that I'm going to discuss. This was the book that was never meant to be a book. I had no intention of writing this book, but over the years, I've been writing the odd article and putting it on social media and on my website and in other places, and then teamed up with a company which is called Conscious Companies, which is literally a corporate-based company which is trying to spread a new paradigm of leadership in the corporate environment, and it's headed by a very dynamic individual with an incredible background, Brenda Carley. And Brenda started looking at a lot of the stuff that I'd written, and she said, hang on a bit, have you got more of this stuff? And gave her more. And in the end she said, this is a book. And I said, in what way? She said, well, if you pull the stuff together and add a few articles that connect it, this really is the narrative of not just of your life chronologically, but the narrative of the evolving concept, which really reflects where I've come from and where I'm at. And so I'm going to just spend a short while. The book, by the way, is on sale here, and I think we've been notified. I think they're going to sell it in the exhibition side later on, so they're going to be available. And we, in fact, we did promote it on air. We launched it officially, but we haven't put it in the bookshops yet because we're not happy with the kind of deal that they're trying to give us, which is quite sad that they're taking 50 or 60%, which is ridiculous. So we sell the books at presentations in the rooms, and that type of thing. It's not on the bookshelves yet, and I'm not sure if it will be. So, going a long way back, in fact, when I was still, I don't know what they call it now, nowadays, giving my age away, used to call it Form 4. It was the year before your final year at school. And I read a book called Passions of the Mind, which was on the life of Sigmund Freud, and I suddenly knew that I was going to get involved with the brain. And but for me, the brain was consciousness, and at that stage, it was the consciousness related to neuroscience. And so began this quest for this thing called consciousness, but being very much a hands-on person, I was always working with wood, etc. It was going to go the neurosurgical route, which is where it went. I was so naive, and this is in the book, and I'm not going to go too much in detail. I was so naive because I was barely passing at school that I decided I'm going to be a neurosurgeon. I wasn't going to do medicine and go to medical school. That's for wussies. I'm going to be a neurosurgeon. And then found out that I had to be a doctor first, which was one of the most traumatic moments of my life, because I had to now get a decent matric and get into medical school, and was convinced, I managed to get in, and was convinced that everyone else was a lot brighter than me. And only in about third year did I realize, hang on, these guys are not that bright. As one of the radiologists once told me much later, who was very good at business, she said, it's not enough being clever, you've got to actually be smart. And so, yes, that was the motto, you've got to be smart. And so began this quest, this consciousness thing. And it then dawned on me that the biomedical model that we use, and I think you guys use, and most people use, I don't think the reflexologists use it. Because I was once horrified to hear, I hope there's no reflexologists here, I don't mean to insult you, but one of my patients who was a brain case, in my field we talk about brain cases, neck cases, and back cases, so this was a brain case or a head case. And she said that her reflexologist massages her pituitary. And I said, that's horrendous. I said, you know that we don't like massaging the pituitary. It's actually not a kind of thing that I enjoy doing. When I have to, I do, but it takes me about 2 hours to get to it, and when I get there, the last thing I want to do is massage it. And she assured me that her reflexology massages it, and I said, where is it? And she showed me just on the inside of her big toe. And so, not really subscribing to the classical biomedical model, but in this biomedical model, there are lots of shortcomings. The biomedical model really is the chemical, tissue, organ, system model without consciousness. Now, you might find that very strange, since we've come a long way in understanding how the brain works. We don't know the whole thing yet. In fact, we don't really know that much, but we have a pretty good idea. We also know that it's the seat of consciousness. And in fact, in a neurosurgical environment, we would use it interchangeably. We would say mind, brain. And in fact, I was giving a talk once in front of quite a few people, about 400. And right at the outset, it was a teaching session, and right at the outset, I said, for the purposes of this discussion, we'll regard the mind as being present in the brain, which I think is a pretty reasonable thing to say for a neurosurgeon. And as I said that, a guy in the front row put up his hand, and that was 2 minutes into the talk, and I thought, no, I can't take this question. So I went into what's called deletion and distortion mode. So if I delete this guy and his hand, it'll disappear. But it wouldn't disappear. And in fact, the hand started making circles in the air, and I had to take the question. And what made it much, much worse for me at the time was that he was an Oxford graduate, and they have that special accent, which doesn't inspire me to be kind. And eventually I said, yes, sir. And he said, how can you be so sure that the mind is in the brain? I thought, this can't be real. In fact, I couldn't even answer this question if I had a half a bottle of scotch. I can't answer this question. And here I am in front of 400 people, and they're all watching my mouth to hear what I'm about to say, and I had no idea what I'm going to say. And suddenly I had this bolt of inspiration, a bolt of lightning came out of the heavens, and it was probably from a neurosurgical ancestor, and I fired back without even thinking, and I said, well, sir, we found that on resecting parts of the rectum, there's been no change in thought processes. Which is a bit cruel. He never asked another question. Yes, so for the purpose of the discussion, and in the biomedical model, consciousness is based in the brain. But the biomedical model doesn't allow this thing called consciousness into the body. Since Descartes, when he was investigating physiology, the church said you can do whatever you want with the body, but the brain consciousness belongs to us. And that commenced what we have today. The biomedical model, sans, meaning without, it's the only French word I know, sans consciousness, sans brain. But we all accept that the brain and its outflow to the rest of the body, which includes the neuroendocrine outflow, which is the brain, prefrontal, frontothalamic, thalamic, hypothalamic, pituitary, master endocrine gland, with hormones that go throughout the body and have a major part to play on the other hormones, on metabolism in general, and very much on immunity. So that connection is accepted. And so when I make a statement, which is a real statement, that depressed women can develop irregular menstrual cycles and in fact can become amenorrheic, stop having periods, simply because of depression, that's a real fact. The question is, why wasn't that integrated in the biomedical model? That emotion can have a direct effect on the physicality of the body. Omitted, deleted or distorted, but omitted. So that's just the neuroendocrine. Then there's the neurological outflow. And the neurological outflow is brain, obviously, lower centers of the brain, brain stem, spinal cord, spinal nerves, cranial nerves, but also the autonomic nervous system with sympathetic and parasympathetic. And guess what? You've just covered the entire body again. You've covered organs, you've covered the immunity, you've covered metabolism, just through sympathetic, parasympathetic. And so when anyone challenges me in terms of the effect of mind states or emotion on the rest of the body, my classical one is they stop me in the corridor and I say, fine, close your eyes, let me take your pulse, and I take their pulse, and I say, right, fine, now think of something that's really frightening that happened to you, that you can recall, and they think of it, and suddenly the pulse rate goes up. Now, what's just happened? We've just had a measurable physiological phenomenon that has resulted simply from an emotion. But there's two sides to this. It's not just demonstrating that there is a mind-brain-body connection. It's also telling us that the brain doesn't really always distinguish between reality and the virtual reality that is stored in the brain in the form of pictures that have an emotional tag. So if you're living in stressful, fearful, anxiety-ridden pictures, fear of tomorrow, for example, then you're living in a high adrenaline state. That's just one thing. So the fact is, and it is a fact, that brain-mind has very powerful connections to the rest of the body, and the immune system, which is one of the receivers of this influence, produces certain chemistry which goes back into the brain. So we've got two-way traffic, serious two-way traffic. And we all need to know that, in fact, we're all secreting and being the recipients of secretions every second of every day. And this is a fact of life. And you ask yourselves, how did this not get into medicine? How did this not get into the biomedical model? Is it in your model? It's not in ours. It's not really in the medical school curricula. And this is a fundamental thing. I mean, this is it. And so we're now seeing from very, very big centers in the world, we're starting to see the chemistry, which is the third pathway. First is neuroendocrine, then there's a neurological output, and then there is a chemical pathway where chemistry secreted in the brain goes into circulation and triggers certain immune cells, such as the macrophage, to produce what's called the pro-inflammatory cytokines. One of the big stimulators, a direct stimulator of the macrophage to produce pro-inflammatory cytokines is adrenaline. Adrenaline is secreted in fear, anxiety, panic, and rage. And if you're in one of those states or more of those states, a lot of the time, you're producing a lot of adrenaline. Your baseline assay of adrenaline and noradrenaline, which is the neurological equivalent, is having a direct effect on your macrophages, which is part of your immune system, and causing them to produce raised levels of pro-inflammatory cytokines. Pro-inflammatory cytokines, by their very name, are the mediators for inflammation. And now comes a really worrying stat, and that is inflammation, chronic inflammation, forms the basis of about 80% of all human ailments. Chronic inflammation is the background to many, many very important ailments. And the other thing is that inflammation promotes further inflammation. And this inflammation can go to any target area of the body. And so let's just look at some of the conditions that have a chronic inflammation foundation, which has been measured. So obviously, inflammatory joints, arthritis, is the obvious one. Inflammatory bowel disease, an obvious one. Migraine has an inflammatory component, a very strong inflammatory component, and in fact, many people obtain relief by anti-inflammatories. But coronary artery disease has an inflammatory foundation. All arterial disease has an inflammatory foundation. Cerebrovascular has an inflammatory foundation. Alzheimer's has a very strong inflammatory foundation. And in fact, the inflammation persists throughout the condition. Motor neuron disease has an inflammatory condition. Parkinson's has an inflammatory condition. And many cancers, if not all, have an inflammatory foundation. In fact, cancer or carcinoma invariably grows from a place of chronic inflammation. Skin, bowel, most of the mucosal-lined passages. Chronic inflammation is one of the major precursors to many cancers. And now we're telling you that there's another component to all of this, and that is a particular mind state, which we've defined. In fact, I've spent the last 26 years defining it. I became involved in this subject in the late 70s, in fact, when it was just being called psychoneuroimmunology or PNI. And then at one stage, there were just two of us in the world that had applied it in a clinical environment. Myself and a guy called Carl Simonton, who was an oncologist based in the US, and his wife was a psychologist. And so he decided to, because he was running an oncology practice, he got his wife to do cognitive intervention with his patients that had cancers. And they did a comparison to see if there was a difference in the outcomes between those who had the intervention, the cognitive intervention, and those who just had the oncology, the chemotherapy and the radiation treatment. And they found very significant that those who had cognitive intervention, their prognosis was 2.5 times better than the others. So if a person had a prognosis of 3 years, for example, they would survive up to 10, purely on the basis of a cognitive intervention, and many were basically cured of the tumor. So very, very important stuff. In the early days, I had to start quantifying this. Remember, I'm not a psychologist or a psychiatrist, and yet we're dealing here with the mind consciousness component, and so I did a course in NLP, Neuro-Linguistic Programming, and then developed the application, which over the years morphed into a wellness promoting program. And a lot of you have done my workshop, which is really about educating you and mentoring you into understanding how the process works scientifically. Remember, we have got strong academic legs in this particular field. We've got 3 coaches who've done master's degrees in different components, different aspects of the program. It's fully validated now. We can actually assess someone who's a high risk, low risk predisposition in terms of illness based on what we can call crudely a spectrum, a vitality spectrum almost, which we've got quantified and which is being used in a clinical environment and in a corporate environment where when we talk about enhancement of wellness, performance, and leadership, because in fact it's very much the same approach. And so it becomes very sobering to understand that there's a major component that's missing from the model that we use. And very specifically you guys, because you guys are very much hands-on, and you need to know that there is a certain chemical configuration that occurs in the interaction between you and the patient, or you and the client. Just to give you an example, and so that you'll understand why there is such a critical need for the integration of this kind of model into this kind of modality into the models that you and I use. If you have a patient or a client who's in pain, and obviously pain has a profile in itself, they have fear with it, so they've got to raise the adrenaline level. They may have had chronic pain, which puts them into a mind state of what we call hopeless helpless. Hopeless helpless are degrees, there's degrees of hopeless helplessness. In its most superficial form, it is someone who doesn't see the point in what they're doing or who they're with or life. In other words, the gloss has gone off life. But they also don't see a way out. They don't see an alternative. So if you put those 2 words together, the one is hopeless. I'm doing something which I don't derive adequate gratification from. And the other one is helpless, that I don't see a way out. I don't see an alternative. Put those 2 together and you're in an entrapment life situation. It gives rise to inflammation. Inflammation gives rise to pain. Pain in joints, pain in wherever, bowel, headache, etc. And so the person comes to you with pain. Hopeless helplessness causes a drop in serotonin and dopamine, which is what the psychiatrists are trying to push up the whole time, under the illusion, and I'm saying this, you can quote me, the illusion that all you really need to do is push up serotonin levels and you'll be happy again. Our experience is that it just makes you a bit happier about your unhappiness. About as good as it gets. Remember that the placebo effect, that is the belief, which by the way has its own chemistry, and it's very important for all of us. The belief in something has chemistry. If you're going to do a placebo, do it well. So don't give someone a purple and brown capsule. Give them a red and white capsule, preferably with a skull and crossbones that says beware, extremely strong. Because that's about 40%. 40% of the effects of oral medication is placebo, the belief that it's going to work. And so I'm painting a picture for you of all potential chemical configurations. Belief, by the way, is associated with empathy, trust, and belief, and it's associated with secretions of high levels of oxytocin. We don't differentiate between the chemistry resulting from a mind state or the mind state resulting from the chemistry. It's irrelevant. They are interlinked, they're integrated. And so empathy, trust, and belief is associated with high levels of oxytocin. Here in Joburg, in a safe, in one of the pharmaceutical companies, there is an aerosol of oxytocin. When you spray that oxytocin in a person's nose, they become extremely trusting and very empathic. And this is part of a study that was done at Harvard, so that the chemistry gives rise to the mind state and the mind state gives rise to the chemistry. Remember, empathy, trust, and belief. Oxytocin further causes raised dopamine, which makes you feel good, makes you curious, drives you, engaging, makes you more engaged, it's a feel-good engagement, and all the higher functions become stimulated, and it suppresses inflammation. So you can already see the chemistry of oxytocin, which is empathy, trust, and belief, drives the good stuff and suppresses the bad stuff. It also suppresses cortisol levels. So that this mind state is associated with the best configuration of chemistry, which has major effects in terms of wellness. Hence, the placebo effect makes you feel well. Conversely, low levels of serotonin, low levels of dopamine, and chronically raised levels of adrenaline, which you're going to see in hopeless, helpless people, or hopeless, helpless plus anxiety, which often goes together, they have got stimulated macrophages which are producing pro-inflammatory cytokines. And you can do whatever you want, and we can do whatever we want, piling on anti-inflammatories until they get renal failure. We're never going to get anywhere until we get to the source of the problem, which is at the brain-mind level. There's a feedback going back, and that is the pro-inflammatory cytokines go back into the brain where they further cause diminished production of dopamine and serotonin, and further compromise this mind state, this negative mind state. They also start causing memory problems and cause atrophy of the hippocampus, which is the memory place, puts you in a vicious circle. And so you begin to understand there's a whole world superimposed on the person that is sitting in the chair or lying on the bed. There is another whole reality. And unless we engage with it, we're not going to be effective. And I'm saying we, because I'm going right across the spectrum of healthcare, right across. The interesting thing was that a certain registrar, surgical registrar in the UK about 20 years ago, before this was really established, made an observation, and this is in the surgical field, made an observation, and that was people that had been in a certain mind state, hadn't classified it yet, but is what we would call hopeless, helpless today. People within that mind state did very poorly post-operatively. It doesn't matter what you did, they did very poorly. And people who were in high oxytocin, empathy, trust, and belief did well irrespective. Because in fact, the chemistry was optimal in terms of recovery, in terms of vitality. So you need to know that the guy, the individual that comes to you, if they're in that mind state, while you do what you have to do, just remember that laying a hand on a person, there's also how you lay your hand and where you lay your hand, which determines certain chemical outcomes. But we know that massage, tactful, in rapport, laying of a hand, massage, raises levels of oxytocin. The converse raises levels of adrenaline. So you need to know where you stand. So if, in fact, you raise the person's level of oxytocin by starting with a gentle hand before you go into the massage and whatever else you do, you're raising levels of oxytocin. You're actually optimizing this person's chemistry, and you're making them more receptive to what you're going to be doing. Conversely, if you show no empathy, if you barge in, you don't establish rapport. Rapport equals empathy, trust, and belief. If you don't establish rapport, then you are going to be challenging. You're going to be a source of anxiety to the person who already has raised levels of adrenaline. If you induce raised levels of adrenaline, you are contributing to this person's inflammation, pain, associated reactive spasm. You're becoming part of the problem. You guys are still okay, because at least you're putting a hand on the patient. My profession is in big trouble. My profession is in major trouble. Let's call them the clinical challenges that we face. Before I'm going on to my profession, I just want to conclude, because this aspect needs to be taken to conclusion. What I'm telling you is not theoretical. What I'm telling you is proven fact. The references, I carry 200 references wherever I go. Big review articles. Everything I tell you is based on fully validated fact. You need to be aware of the chemical configuration of the person sitting in front of you. And you need to understand that if a person is high on adrenaline, which is associated with fear, which is associated with chronic pain, and low levels of dopamine, serotonin, and oxytocin, that you need to come in bending the page further back to come out with a straight page, because this person is in trouble. If you don't acknowledge their pain, meet it with the appropriate degree of sensitivity and empathy, and then move to gentle touch, to massage, etc., then you are going to induce reactive chemistry, which is going to be counterproductive and going to put them back further than they were before they walked in. So that's the component that you need to have. If, in fact, you go the right route and you do it in a logical, connecting way, sensitive to the feedback that you're getting, then you will have a happy customer. Then you will have somebody who will regard, as a consumer, not just as a patient, as a consumer, that they've got value for their buck. Because at the end of the day, unfortunately, not so much you guys, our guys don't put a hand on people anymore. And this for me is horrendous. This is a shocker. And I didn't realize this is what's going on. I regard myself as being fortunate in that I had a mentor, and that's in the book, all about my mentor. I was very, very lucky. I had a mentor. I had a mentor who was trained in the UK in the old British clinical way, was a masterful pair of hands, had been a GP, so had developed connections and sensitivity and empathy with his patients out in the platteland, who then became a neurosurgeon, trained again in the UK, and then was my mentor, and he trained me in the science and the art of neurosurgery. But a lot of our time was spent at the bedside. In my time, the examination was a major part of the whole workup. In fact, only right at the end did you decide, well, we'll do the scan or the CT or the bloods or whatever to supplement and to clarify what the definitive diagnosis is. And sadly, with each consecutive subsequent generation, this has been lost. And it's moved from the old British way to the US way. The US way is purely technological. And so diagnoses are made on the other side of the table. No hand is laid on the patient, which is a major problem, because if no hand is laid on the patient, you don't have a neurological or a musculoskeletal evaluation. You go straight to high tech, you go straight to MRIs and whatever else goes with it, even nerve conduction studies, which themselves are problematic, a lot of false negatives, false positives, until you now sit with the results of investigations, which you now have to interpret in the context of the person sitting in front of you, whom you've not examined. Now, let me illustrate why this is so problematic, because I think I mentioned this once before at one of your meetings, and I'm going to mention it again because it's a critical corner that is becoming very problematic, and that was, we see a lot of stuff, as you know, on an MRI scan. The question is, how much of that is relevant to this particular person's symptoms? And so one day they decided to do the study in London. They took 100 people off the streets who had no back or leg pain, who had never had any significant back or leg pain, and gave them a free MRI scan. And 40% of them, 40 out of the 100, had very significant pathology seen on an MRI scan without any symptoms. So now the problem now is that this person that was sitting in front of you, who presented with a problem, you now sit with a scan. Now you've got to go backwards. How are you going to interpret the scan? What is relevant in this scan to this particular person's problem if you never examine them? And if you've done more than one investigation, it's even more confusing, because now you've got to try and piece it together. You can't piece it together from the top down. You can only piece it from the bottom up. Bottom is hand on the patient. Even before that is a history. The history gives you a pretty good idea of what you're dealing with. okay, fine, I've got experience, I've been around in neurosurgery for 36 years, but if I see a patient walk in who tells me that they had pain in the neck and they went into the shoulder blade, down the arm, pins and needles in the hand, and they get relief by doing that, it's a C6-7 disc prolapse. That's it. Just on the history, I already know what I'm dealing with. I go and examine, yes, fine, we've got weak triceps and tricep jerks gone, and C7, C6-7 sensory loss. That just confirms it. Believe me, the scan is really just giving me the configuration of what I already know. But you've got this American system, where, by the way, they are so far removed from the clinical environment that what I've just told you is not known to them, to most of them. You won't find it in a textbook. You won't find in a textbook of neuroscience, neurosurgery, neurology, that a patient who has a C6-7 disc prolapse has the first symptom in most cases, I can almost say most cases, going to the shoulder blade, because that's also supplied by C7. It's an aberration, shoulder blade. If you hear shoulder blade, down the arm, pins and needles with or without in the hands, relief by lifting, which you don't find in a textbook, 6-7. These things, that comes from a clinical engagement. And so they could be sitting without having examined the patient, without really having taken a comprehensive history. They get an MRI scan done, and they've now got C4-5 and C6-7. What's the interpretation if you haven't examined the patient? Well, yes, C5 goes to the shoulder. Is this C5 significant in the context of this patient? This is a very inconvenient case to do surgically, but they'll do it because it's a skip lesion. So they end up doing 4-5. They may not even do 6-7. And your patient wakes up with the same pain. And so I was absolutely horrified when I heard, and by the way, this is now becoming the mode in this part of the world. It wasn't like this before. We had followed the British system. Now we're following the Yanks. And I can tell you that we, myself and my associate, are preferred provider for US missionaries in Africa. And we have been for more than 20 years. And so we get a lot of the American patients coming down to us. And we found that patients were finishing their tour of duty in Africa and coming down to us before going to the States. And once or twice I'd asked, and eventually I understood, I didn't ask anymore. I said, just out of interest, you know, you're sitting in darkest Africa. You're now going back to the US of A, first world. Why are you coming to us for your healthcare needs? And a lot of them want their scans and they have their surgery before they go. And they said, because we don't trust the doctors in the US. And I said, how so? And they said, well, number one, they don't come around from the other side of the desk, and we don't trust their opinions. They don't trust the specialist opinions in the US. They've lost confidence in the specialist opinions. Number one, because they're not examining, and number two, because they feel they have such a vested interest in the surgery that they're not giving them a valid opinion. That's a nightmare. That is a disaster. And that is sadly starting to happen in our environment. And so when I say to you that I'm not doing more than we were all trained to do. But you know, in the world of the blind, those with one eye are king. Well, there's less and less of us examining our patients. There's less and less of us coming to a diagnosis. And it's absolutely horrendous. And I am not blowing my trumpet. I am just telling you that I'm doing what I was taught to do, whereas no one else is being taught how to approach a neurological or a neuromusculoskeletal problem. They're just not doing it. And so there's an important message here, and that is you need to engage. You need to take a full history. You need to examine fully. And then you need to decide on the most appropriate treatment for that particular problem, which is the full spectrum of what we all have to offer. Which brings me to the subject of the diagnosis. You know that ultimately there is a diagnosis. There may be more than one. We can call it a primary diagnosis, and there are secondary diagnoses. But we are all, us, across the healthcare spectrum, and all our patients, need to work after a specific diagnosis is made. It is all very well to go along with a soft clinical presentation, meaning that there's local pain with maybe vague referral, and to treat that conservatively for all of us. And if we found on examination there's no significant neurological problem, that's fine. Referred pain is fine. It's quite an acceptable reflection of a primary pathology. But if there's neurology involved, real neurology, in other words, it's following a dermatome, it's following a nerve, you and I and everybody else in healthcare requires a diagnosis. We have to make a diagnosis. We have to test it mechanically, straight X-rays with stress views of cervical and lumbar, and we need to get a definitive diagnosis and then decide if the diagnosis reflects what this patient is presenting with, and if indeed we've got a neurological compression, then those who deal definitively with neurological compressions of a severe nature, which is us, need to evaluate. But sadly, and again, last time I spoke about a patient who was manipulated with an unstable neck, a really unstable neck, who came to me quadriparetic. I'm not going to go over that case again. We exhausted it the last time. We thrashed it. Anyway, it's there. We've spoken about it. But I'm now talking about patients who have hard neurology, hard ridiculous stuff, with or without a weakness. We become very twitchy when there's a weakness, who are being managed for 3-4 months before referral. Now, there's one nerve that doesn't like being compressed and being manipulated and being stretched without alleviation, and that is C5. C5 does not like to be left compressed, especially if there's a deltoid weakness, because a deltoid weakness deteriorates and you've got a permanent deltoid weakness. That nerve, for some reason, doesn't like it at all. C7 lesser. The more resilient is C6, but C7 also slightly better than C5, but also doesn't like severe compression for too long, and it's an important nerve. It is wrist extension, triceps. I mean, did you realize that the first sign, and I learned this from a patient who played darts, the first sign of C7 is not being able to play darts. And to test recovery is, how's the dart game going? What, I haven't got to the board yet. I'm still below the board. Interesting. Throwing darts is a pure C7 function. And so a diagnosis has to be made. We cannot go on indefinitely when there's a neurological problem. And this applies to you guys, to us, to the physios, where a diagnosis has not been made. A diagnosis has to be made. We have to then share it across the board. Everyone does what they do best under a diagnosis. If, in fact, there is a scan done and there is compression, but there is still a little bit of space, function is not totally gone, there would be room for conservative management, but to go easy on the manipulation because we don't have much of a margin of safety. Ding the nerve. Remember, when you ding the nerve, you're not just compressing the nerve, you're actually compressing its blood supply. So in fact, you're compressing the nerve and its blood supply, and you're giving the nerve a micro stroke, essentially. That's what's happening when you're compressing a nerve. And often, when we've gone in surgery, when there's been severe compression for too long, which, by the way, determines the outcome. So if, in fact, you've been compressed, you had a compression for too long, that directly affects the reversibility of the problem. So the longer the compression, the more pronounced the compression, the more severe the clinical situation, and the more prolonged the recovery is going to be after decompression. And then there's a very strange syndrome when there's been severe compression, and we do a decompression, and I know this firsthand, they sometimes get a recurrence of severe pain in the same distribution as the nerve. And in the old days, in one or two cases, we were so worried that a day or two later, where they were clinically free, the first day after the op, second and third day, they had this burning pain down the same distribution. And I remember going in on one or two necks in the old days, when we were still doing bone grafts from the hip, and took the patient back to theatre, took out the block of bone, looked into the back, and saw a nerve that was blood red. It was what we call hyperemic. So after being compressed for so long, you get a hyperemia, and then slowly that settles down after a couple of weeks, and then things have settled down. So these are some of the considerations. Then there is a nasty space, which is affecting all of us, which is being perpetrated by all our colleagues, sometimes inadvertently by ourselves as well, sadly, and it's called iatrogenesis. It comes from Greek word, I didn't realize that. It actually comes from Greek word, one of the Greek patients told me. I was trying to be clever, I said, he had a serious problem from a previous lumbar decompression. He had a total foot drop, which he didn't have pre-op, so he had basically post-operative damage. And I said, he was a Greek guy, and I said, this is iatrogenic. And he nodded. I said, do you understand that? He said, yeah, it's Greek. I said, that's all Greek to me. So he said, iatros. I said, yeah. He said, iatros is doctor in Greek. Genesis, to cause, to create. It's doctor created trouble. Iatrogenesis is problems created by the practitioner, and we're all to blame. And we need to be very aware of what we do, because we don't want to add to the problem. Because iatrogenesis in the States is becoming one of the leading causes of morbidity and mortality. Iatrogenesis across the board. Medical, wrong medication, too much, too little, wrong time, wrong combinations, wrongly given. Your hair will stand on end if you have to read these case studies, what's actually going on in hospitals, and we're seeing it sadly here too. Wrong medication given to the patient, reacts with something else. And then, of course, the massage, the manipulation, when there shouldn't have been manipulation, can cause a neurological problem, and surgery, a big, big problem. Iatrogenesis in surgery at the moment is a nightmare. It is an absolute nightmare. Because we now have, often, preceding pathology, intraoperative something which we don't know, and plus the post-operative appearance, the post-operative reconstruction of what probably should not have been constructed in the first place, becomes a major, major problem for all of us. Seen against the background of less and less qualifying spinal surgeons. So, I don't know if you're aware of it, but we're in the process of a crisis. We are losing spinal surgeons at a rate you cannot believe anymore. And what do we have coming out? Well, let me tell you what faces. Let me describe to you, and I don't want to run our profession down, but this is the reality that we're dealing with. Emerging out of the training environment are poorly qualified people. And when I heard what a particular group of guys, senior registrars, were being trained to do, I absolutely shudder. Because they were told that when the patient has radicular pain, lumbar spine, they must do a laminectomy. And I said, yes. No, that's it, laminectomy. I said, yeah, but what about the disc, the nerve, No, we're told all you need to do is a laminectomy. And that is, by the way, gospel truth. I could not believe what I was hearing. Now, these guys are coming out. They have not been trained in the micro side of spinal work. And I've got no one to teach. Because Wits Medical School, in their wisdom, would not allow us to rotate registrars through private practice. And I can't train in the hospitals because they don't have the equipment in any case that we use. So my heritage, all that came before me, my mentor and all the great names in neurosurgery and spinal work, dies with me in this country, which is an absolute nightmare. And so we're the last row on the bus, because coming out now are guys who are poorly trained, who have to make a quick buck, because as of the beginning of this month, the malpractice insurance, the Medical Protection Society insurance premium for spinal surgeons has gone up to 50,000 Rand a month. So that means that a guy coming out into private practice has to turn 50,000 Rand for that month, plus running of the practice, before he or she can earn a living. So that's going to unfortunately default back onto, let me get my hands on a neck or a back. And what this is going to do is just compound a problem, spinning us off into a very, very bad place. And you've got guys that are holding on to their positions in state hospitals who are freezing posts, so there's less and less space for these individuals, and they've got to come out. And this is who is coming out. And we have a major problem. And we can't cope. I mean, those of us that are left really can't cope. And so we have a big problem. One would have hoped that it would have defaulted back to a safe space, but human beings aren't like that. Human beings default back onto priorities, and their priorities are to make a living. It's probably too dangerous for these guys to practice without insurance. I practice without insurance, simply because I'm just not prepared to, in principle, take this on. I rather sort of practice decent medicine. Which brings me to another point, and that is, if in fact the guys are not examining the patients, you know that it has been said that the potential litigant in my side of the healthcare spectrum, the litigant is someone who did not experience your sensitivity and empathy to their situation in the first 2 minutes. If in fact they came in, as they do, the patient comes in with chronic pain or a new pain or an acute pain, but especially the chronic pain, because it's been going for a long time. If the patient with the chronic pain comes in, especially if they're slightly obese, there's a double dose of empathy required. Not empathy, sensitivity. And unfortunately, the guys will default. Number one, they won't lay a hand or they won't examine because they've already decided you're fat and you're a poor surgical risk. If they think that, they communicate that. And if you do that, you've basically just gone and blown any rapport that could have been. That person despises you for not showing the sensitivity that you should have. You never examined. You're going to get hit badly for that. And that happens in the first 2 minutes. And so my guys are defaulting back onto needs, financial needs. The heritage of clinical engagement has been seriously diluted out by the American technological way. There's no rapport to talk about. There's no real clarity in terms of identifying what the problem is. There's a high predisposition to unnecessary, excessive, or even wrongful surgery. And another whole iatrogenic army of failed spines sits on our doorstep. So these are the issues that we're facing at the moment. You guys are hands-on, and the other areas of the spectrum of healthcare who are hands-on, you need to know that you're probably the last guys that are hands-on. We're in a mess. Patients are not being examined anymore. Yeah, it's not a good space, not a good space at all. At the end of the day, there's a thing called taking ownership. And we, the practitioners, need to take ownership, which is really about taking responsibility for what we do. But we're living in an environment, not just locally, but very much locally, we're living in an environment which is lacking in accountability. And the guys are going to be doing the minimum required just to stay on the line of safety. But we're living in an environment of less and less accountability. And those who have an insurance say, well, what the hell, I'm covered. You can fall back on that. The fact is that every time the guys say, what the hell, I'm covered, they push the premiums up again the next year. Until we're outstripping the ability to carry this kind of insurance. So we're actually asking the bottom line here, the absolute bottom line here, is accountability. Are you taking responsibility for everything that you're doing? Forget about the medical legal side. Let's just talk about your patient client as a consumer. Does the consumer get value for their buck? Are you taking responsibility for the consequences of what you're doing? You guys are lucky. I don't think you're being hit that badly yet, but you're a soft target. It'll come. When they're finished with us, they're going to start anew. You need to know right now, from this safe space now, that you need to take responsibility for what you do. The consequences are yours. It'll come back to you. Or you need to know that the person that went through, you're going to have peace of mind and hopefully job fulfillment. That what you've done was beneficial to this person, that was of value to this person. That's really where clinical healthcare is based. That in terms of the Consumer Protection Act, that the person comes to you for a service, that they're going to pay good money to you for a service, that you are basically delivering a good service to the best of your ability and based on all that you are, all that you've been taught. You have to deliver the best service that you possibly can to ensure that this person gets value for money. You also have to have another little red flag which gets raised when you start making a judgment of the person. As soon as you make a judgment of a person, it's usually disparaging. So refrain from making a disparaging judgment, even if it's in your head, because you're communicating it. And if you've made a judgment, it's going to bias what you do. It's going to bias how you behave. It's going to cause you to minimize the required sensitivity and empathy. And that's going to impact on the chemistry, and that's going to affect the engagement, the actual clinical engagement between you and the patient and the client, which you're going to be responsible for because they came to you for a service. They came to you for a value contribution, and you charge them good money for it. And so you need to know that you're making a positive difference. You are a value contributor. The Consumer Protection Act requires that, number one, you are upfront with the person, that you are honest, that you fully understand who they are and where they come from, that you fully explain what you're going to do, that you fully elucidate what you expect to be the outcome of what you're going to do. What is it that you do? What are its consequences? What are its benefits? What can go wrong? These are the things that have to be communicated. The Consumer Protection Act covers all of us. You can forget about your local societies. You can forget about the HPCSA. Yes, fine. And your allied professions, they register you. But the organization that has the final say is the consumer protector. Because in fact, there is a very clear-cut description of what service providers have to provide. And if you don't, you've fallen foul of the consumer protector. And the patient, who is a consumer, has certain rights. You and I have very few rights, sadly. We've gone through them. We can't even find more than 2. We hardly have any rights in terms of the Consumer Protection Act. The patient-client has all the rights. You need to ensure that you're on the right side of the Consumer Protection Act, because that's the thing that will clap you in a civil case. Not just your society, but in terms of the Consumer Protection Act. You have got to, number one, be accurate in your evaluation. Treat the person civilly, not make a judgment, understand where they come from. Act to the best of your ability to ensure that you provide the greatest value that you can based on who you are and where you come from, and that the money that is paid is appropriate for the value contribution, and that you take responsibility for the consequences, because a consumer is covered after the service is provided. So just remember, by the way, on the ethics side, we're governed by the Consumer Protection Act, and the patient has all the rights. We have very, very few rights in terms of the Consumer Protection Act. And so, finally, we all need to know what we do best. We all need to know our individual limitations. We need to share what our thoughts are of the patient, what we've done, the history, and what is realistic and what is appropriate, that each one of us can contribute to a particular person's situation. You may or may not know, we've spoken about this before. I come from the bad old days, where the Health Professions Council was called the South African Medical and Dental Council. It was a feared organization. It only registered doctors and dentists. No one else was regarded as being a healthcare provider of substance. Obviously, there were the paramedicals, which was physio, OT, etc., and those were the only people that were registered. And when I came into practice, which was in 1988, I don't know if some of you were even born then. When I came into practice in 88, we were not allowed to talk to you guys. It didn't matter that our patients were rotating through chiropractors, physios, and us. We were not allowed to talk to you. And in fact, I sent a famous letter. I've always been a maverick, as you'll see in the book. I thought, you know what? I used to speak to quite a few of your colleagues, your older colleagues, and I thought, you know what, this is ridiculous. We've got to talk. So I sent a letter to the registrar of the South African Medical and Dental Council, which was pretty straightforward. It said, "Dear sir, we're seeing the same patients. They're rotating through us. Chiros do what chiros do, physios do what physios do, OTs do what OTs do, and others, and personal trainers in gym who are an eternal source of material for my practice." And I mean, some of the things that have been done, you just got no idea. I mean, I looked at patients, I said, you're actually joking. I mean, the one patient was made to pedal on a spinning bike for 1.5 hours continuous. The guy was 68. How he didn't have a full-on cardiac infarct on the spot, I don't know, but his spine was shot. I mean, that was a personal trainer who was following some story. So I said to in my request, I said, well, look, we're seeing the same patients. They're coming through us. I think it's in the patient's benefit, to the patient's benefit, that we collaborate, that we dialogue, that we talk. So 1 week went by, 2 weeks went by, and your conference was coming up in that year. It was at Bergendal at the Kruger Park, and I was invited to be the keynote speaker. And eventually, I think it was a month before the Congress, I got my answer from the South African Medical and Dental Council, which was firing off the rules for a doctor to remain registered, and then a warning at the end. And God help you, pas op. You talk to those guys, you finished. That was the answer, which I've still got. I got this letter. And so I promptly went off to the Cairo Congress at Bergendal, where we had a hell of a great time. And I was waiting for the guys in dark suits and clipboards to do the execution outside, which they never materialized. And then a couple of years later, we were collaborating, as we ought to, because at the end of the day, it is in the interest of the consumer, who happens to be our common patients. And yeah. So finally, obviously we're going to have a lot of chats. I can see a lot of clenched fists and clenched mouths. We're going to have a bit of a powwow. Do you want a drink? I just want to add one thing, and that is it's not emphasized enough. It's on the conservative side, and that is lifestyle modification. I think it's a critical space. It applies to all of us. I don't think it's ever been emphasized, and so I'm emphasizing it now. Irrespective of the modality of treatment that is given, we have a whole population with a heritage of very poor lifestyles as regards spinal management. That the basic principles, I'm just going to rattle them off. The basic principles are that for the lumbar spine, when it's become chronically symptomatic and there's chronic degeneration, we don't like jumping, kicking, stamping, and jogging as a basic rule. Short sprints, yes, fine, within reason, but we found that those activities tend to aggravate chronic spines. Impact also tends to aggravate cervical problems, and jogging, unfortunately, is one of those. And I had a patient who was a pediatrician at our clinic who was a serious marathon runner, and he said he had a severe neck problem. I brought him in for traction. And he said, right, he's just having the traction because he's got another marathon next week. I said, don't do that, because in fact, it's going to just undo everything we've done. He said, no, it's the neck. Jogging is for the lumbar. I said, believe me, we're going to have trouble. And sure enough, after the next marathon, he was in absolute agony because it gets transmitted to the neck. And I think you need to realize that. The second thing is that as regards the neck, it doesn't like unguarded movements. Unguarded movements are rapid movements which were never foreseen. So if you want to wreck a neck, do an activity which has got a lot of potential unguarded movements in it. Also, sitting on the back of a game vehicle, not anticipating when you're going to be thrown around, is bad for a neck. And I had this experience myself. Fortunately, we had a soft collar there with us, because one of the guys had severe pain on the game drive, and I had to strap him up with a soft collar because it was killing him. So unguarded movements for the neck is bad news. So impact and unguarded movements for the neck, jumping, kicking, stamping, jogging for the lumbar spine in a chronic spine is not great. Posture is very, very important, especially people who are sitting for long periods of time. We don't like people lifting things while they sit. We don't like heavy lifts for people with bad backs. It's pretty self-explanatory. There are ways of lifting, obviously bending knees and using knees and hips, and splinting your spine. Even with my shot back, I still help turning patients, and that is, I splint my back. Essentially, just splint my back and let the shoulders, elbows, hips, and knees take the strain with a splintered back, a rigid plank back. But picking up heavy weights is never a great idea. And so, what I'm trying to say here, without going into these are just the principles, going into the details of it is critical. Because in fact, if you've got someone doing something stupid the whole time and you're trying to sort it out, you're never going to win. Same way as if you've got someone who's caught up in chronic hopeless helplessness and producing the wrong chemistry, doesn't matter what you're going to do to their joints, they've got inflamed joints, and that's all there is to it until they sort out what is causing this hopeless helplessness. So basically what I'm saying to you is, you're going to have to become aware of the person in front of you in a multidimensional way, because it is the chemistry, the mind state, the physicality, and this full spectrum of physicality, which has a major part to play in the ultimate outcome for which you alone, for that part of the intervention, will be held responsible at the end of the day. So I reckon that's about it. I'll just end off with the one study. I think I've spoken about it before, at the last time that I spoke, and it was an interesting thing. It was done by a Canadian guy, and what he did was he looked at an enormous spectrum of modalities of intervention for a lot of people. I think it was about 25,000 cases over about 10 years. And these were people who had spinal conditions, and they had received everything from lifestyle, conservative intervention, physio, chiro, and others, massage, surgery, the very conservative surgery, the more radical surgery, the reconstructive surgery. And he looked at the outcomes after 10 years, and he found that 50% did well and 50% didn't, irrespective of what was done. And that is a very, very sobering figure. In fact, that is a whole story in itself. My particular area, as you know, is I've sort of moved away from radical surgery. I do microsurgery. In fact, was one of those who contributed to the development of microsurgery. I try to make smaller and smaller incisions. In fact, at this point in time, those of you who've been in theatre with me will see that we're now struggling to get the disc prosthesis in because the skin cut is so small. And I curse, and my theatre sister always rolls her eyes to the heavens because I've done it again. The incision is just too small, and I'm battling to get the disc prosthesis in, but invariably we get it in. In fact, we do double levels through the same cut. So my great contribution was minimalizing the trauma, if I could, with our disc prosthesis. And as you know, we're now into our third generation cervical prosthesis. We've now moved away from metal. We're now into composite. And I'm going to tell you some stuff which is very new, hot off the press. Our factory, call it our factory, but we're not involved now with the next generation. That's really over to the engineers. We were cut loose when we eventually perfected it, both for lumbar and cervical. We were into heavy metal. It was not a band, but it was a prosthesis. It was a cobalt chrome metal on metal prosthesis for cervical and lumbar. The lumbar is still heavy metal, which has now run into serious trouble in the US because there's this whole class action against chrome poison because hip replacements are made out of chrome, cobalt chrome. And our disc, which was originally in 2001 was titanium with polyethylene, which was the most beautiful disc, they wouldn't buy until we turned it into cobalt chrome, and now they're stuck with it because they're in trouble. So the cervical, which is my area where sometimes I'm forced to do fusions. I don't like doing fusions for the obvious reason that it takes away movement, but the disc is composite. It is PEEK, polyethyl ethyl chloride body, with a hardened ceramic core, and we've got a sprayed-on titanium surface, which is done for us in Milan. It's the only place in the world that does spray-on titanium, and why? Because the bone doesn't bond to carbon fiber. It will bond to titanium, sprayed on titanium, so we get them sprayed and bring them back, and then distribute them. So that's our composite. And in August comes out the first compressible core. So we're going to have almost a physiological disc replacement. So we're going to have a compressible core. What they've done is they've cut the core in half, hollowed it out, and put in a silicone compressible internal. And so we're going to have full movement with a compressible shock-absorbing core, which is the first in the world, made no further than Centurion. And so that's very exciting for us. We're going to have a compressible cervical disc from August, first in the world, and we're pretty chuffed with that. That's physiological. And that's really the full spectrum. So I think we've covered quite a bit here. The only place we didn't go into is quantum physics. But then I'm a neurosurgeon. You don't have to have a rocket scientist if you've got a neurosurgeon around. I'm sure you've seen that little clip. It's quite interesting. I'm just going to end off and tell you why. And it's in the book, by the way. You've got to get this book. I mean, it's a must-read. It's not even a discussion. It's changing lives as we speak. Why did I end up going into this weird world of quantum physics? I'm just going to quote one case, one concept, why I had to go there, why the biomedical model was inadequate, and why the biomedical model together with PNI, the psychoneuroimmunology component, was inadequate. Because we have, and I'm going to leave you with this one, it's on a cliffhanger because there is no real explanation for this. You see, every now and then, an inconvenient truth arrives where the masses can't consume it. And by the masses, I'm talking about the practitioners, my guys, can't incorporate it, can't integrate it. And so I'm going to tell you this one because this one is a real difficult one. There is a series published series of about 300 cases who manifest a concept called terminal lucidity. Terminal lucidity is the following. It's patients who have terminal dementia, who for the last several years have no ability to manage themselves. They have no cognition. They do not recognize anybody. They need full-time care. And they have been in that state for several years. And scans which have been performed on them have shown gross atrophy. There's not much brain left. So in other words, the condition corresponds to the scan findings. There's severe cerebral atrophy for a person who is totally dependent on care and has no recognition for anyone close to them. And suddenly, 4 to 6 hours before their death, they become totally lucid. They recognize every single person and are fully up to date in what has happened up until that moment, and then die. And there's 300 cases published with no explanation. No explanation. You see, every now and then the universe throws a curved ball, and we're going to have to receive it. But the problem is it's just too inconvenient, and the model just can't be stretched that far. Well, I took a shot at it. It's in the book. So the book's going to be sold a little later on, I believe, in your exhibition area. Over to you. So here's where you can flex your biceps and see if you've got a dart-throwing muscle and throw it at me. You all happy about that? Yep.
This is the most random question ever. No, I'm going to blush now. Moment's too big. We need to for the people listening.
There's
Okay,
no stupid questions, so go for
No,
it.
but this is a personal question towards you. Do you ever go for chiro treatment?
That's an interesting question. No, I never have. By the way, I've never gone for massage either. I've also never gone to physio. So it's a fair question. That's my fair answer.
Just be quiet and do it.
Say again? What about trying? Well, actually, yeah, maybe. Maybe after the next heavy list. 2 weeks ago's list was 14 hours. I felt a bit of an ache in the back. Maybe if you guys are available at 10 o'clock at night, then maybe we'll make a date. So everyone's happy to engage in this cruel world? Yep.
What are your thoughts on the tools to sort of calm your reticular activating system down, to make that adrenaline settle down? So it's something I use quite a lot in my practice, is giving people tools of little things to do for themselves at home to try and help them, I suppose, get out of that helpless, hopeless state and to calm their systems down. Because what I'm finding with people more and more is that they're coming to you and when the lion's chasing them, they're jumping over the 10-foot fence, but their systems aren't calming down. And that practitioners like us need more and more to actually give a patient the tools of little things to calm that system down themselves.
As you will glean from the book, I'm also heavily involved with coaching. So I do coach in the corporate and in the clinical environment. And it's a very common problem. This hyperadrenergic anxiety state, whether it's overt or sort of subtle, prevails at a very high level. And there are different kinds of approaches. The first approach is, number one, why are you in this mind state? So it's part of the history. Why are you in this state? And the common causes are, number one, I always have been, so there's a nurture deprivation kind of induced tendency to a high anxiety, anger, panic type state. Or there's an environmental factor, or both. In other words, an environmental factor has triggered memories of nurture, which has now brought up this anxiety. So anxiety is sitting in the amygdala. Fear, anxiety, panic, and rage is sitting in the amygdala, and there's a pair of them in the deep temporal lobes on each side. We have to ask ourselves, what is the antidote to fear, anxiety, panic, and rage? Well, we know physiologically, and that's in the book, physiologically, hard neurophysiology, how do you quieten down an amygdala? Well, if you do something meaningful and purposeful. If you engage meaningfully and purposefully and you experience the gratification from doing it, you quieten down an amygdala. And that's, by the way, has been done experimentally. Our guys have put electrodes into the nucleus accumbens, which is the seat of dopamine secretion, pushed up dopamine levels and created gratification and fulfillment and engagement, in other words, meaning and purpose, chemically, electrochemically, and then put those patients into a PET scanner, which is not a CAT scanner is for cats, PET scanner is for pets. PET scanner, positron emission tomography scanner, which basically gives you a measure of what's most active in the brain at that point in time based on glucose metabolism. And in those patients who were stimulated in terms of their nucleus accumbens, which has been an electrode in the nucleus accumbens brought under the skin to a pacemaker, and they're being paced for a couple of months, the amygdala became quieter. So the first place is to create meaning and purpose. The meaning and purpose already quietens down the amygdala. That's the first thing. So coaching towards meaning and purpose. And there's a whole string, and the coaches here in the group will understand that you've got to go through a personal mission statement, find out things that turn you on and things that cause you anxiety, and then move towards doing stuff that gives you personal gratification. That calms the amygdala. The other thing is mindfulness stuff. In other words, come back in the present and stop worrying about tomorrow, because 90%, and we go into what's called disputation. Dispute the things that you think cause your anxiety. So worrying about all the negative things of tomorrow, most of which never happen, and say to yourself, do they always happen? No, they don't. That's disputation. So that's one of the coaching techniques that we use. And by the way, this is at the cognitive level. So the other place that quietens down the amygdala, very much so, is the prefrontal cortex, which is where we reason, our reasoning center. And finally, empathy, trust, and belief. The secretion of oxytocin quietens down the amygdala. Here's an interesting one. I heard this from somebody being in the Israeli army. And what they do is when they've got guys who go into a panic state, and they're guys in armies that go into panic states. I was a military neurosurgeon. I've seen it myself in the field. The guys go into a panic state, a real frozen panic state. In other words, the amygdala goes into fight, fright, or freeze. Fight, fright, or freeze. And a lot of the guys freeze. They become useless. And those guys get killed because they can't react or proact. And what they did in the Israeli army is that they take these guys and they make them help other guys who got major wounds. And just becoming meaningful, sensitive to, empathic of, neutralizes that amygdala. Just some applied neurophysiology. So the kind of coaching that I do is called neuromodulation, because my coaching is based on a neuroscience model. So I'm very aware of all this chemistry that I've been telling you. That's how I actually approach a person, because I'm actually engaging with their chemistry. That's the long answer. Yep.
So it's a two-pronged question in the sense that both in your clinical practice, but also then potentially from a research point of view, the subjective component of intention of when you're dealing with the patient, both in the consultation and having rapport and meaningfulness, as well as in surgery or in theatre. How much have you found it to be of value? Is it there? How important is it? Is it not meaningful?
So let me just clarify this. So you're asking me in terms of what I've described as being the optimal approach.
Yes.
Okay, so what I've described in the clinical environment applies to all of us. Okay, we have to establish rapport by being sensitive to, empathic, and ensuring that we are going to contribute value to the best of our ability. That's universal. That applies to all of us. That we subscribe to the fact that the good money that's being paid has met with the appropriate value. Okay. Then we come to the theatre environment, the surgical environment. And now I'm going to tell you something which might shock you. That OR, as they call it in the US, the OR, the operating theatre, is a place of great fear, not just for the patient, but for the surgeon as well. And herein lies the problem. I mean, a lot of you guys have been in my theatre, and look, at this stage of my life, there's not that much fear, but God help the guy a surgeon who walks into theatre saying, this is just an L5S1 disc. That little just L5S1 disc can turn out to be an absolute nightmare. And so it's a place of fear. So for the patient has got a lot of fear. Practicing what I preach, I will invariably see the patient when they're still in the bed waiting area. I call it the bed wetting area because that's where there's a place of great fear. The bed wetting area, and I make a point of reassuring them, and as I said to you, I place my hand on their ankle. And I said, don't worry, I'm having a good day today. And that already, I'm having a good day today. And that already allays a lot of fear. And yes, then they're going to go in, they feel a bit better, pulse rate goes up as they get induced and they go to sleep. For them, fear is over. But a surgeon who comes up against a problem, and it's usually hemorrhagic, a bleed, color red, puts up a red flag, goes through several processes. The first is raised adrenaline. What does raised adrenaline do physiologically? Raised adrenaline, which by the way is coming from the amygdala, which by the way gets locked into a vicious circle because the amygdala manifests fear, anxiety, panic, and rage by secreting adrenaline and cortisol. But it's a quirk of nature that the amygdala is also stimulated by adrenaline and cortisol. So they get caught up in what's called a locked-in syndrome, a locked-in amygdala. So the fear, anxiety starts getting worse and worse and worse, and the adrenaline starts rising higher and higher and higher. And what does raised adrenaline do? It wipes out the prefrontal cortex reasoning ability. You actually lose your reasoning ability. Now we've got a patient hemorrhaging, a surgeon who's gone beyond amygdala, he's not thinking anymore, who can't even remember what they can do, what they can't do, what the solution is to this particular problem. This is life-threatening now because the surgeon is becoming ineffective. And sadly, I've been called into theatre once to a posterior neck, which, by the way, is one of the most dangerous places in the world to operate. Posterior neck is worse than the anterior neck. And there's a lot of surgeons who don't like to operate on the posterior cervical spine. It bleeds like hell. And in this particular case, the patient almost bled out. The patient was near arrest because they couldn't control the hemorrhage. I found a surgeon who was absolutely blabbering. You couldn't actually hear anything intelligible the orders that he was giving to the scrub sister was almost unintelligible. And I knew that he was completely and utterly locked into amygdala, locked in. No more reasoning. Hopeless, helpless. Gone. And so I said, and there were swabs packed, and there was a spinal cord in the middle, and there's swabs packed all the way around it. This is not a nice looking story. And anaesthetist in absolute tiz, trying to catch up with fluids, and there's just blood swabs all over the place. And anyone who want to faint, you can just lie down. And I said, okay, just show me where the bleeding is coming from. And he lifted, and I said, okay, fine, I got it. I said, why don't you just go out? Why don't you footsack out of theatre? Go out of theatre, you're useless. You're useless to yourself and to anybody else. Go out of theatre. Go and find your amygdala. Well, you've got your amygdala. Go and find your prefrontal cortex. And so I had to then, I was busy consulting, so I had a waiting room full of patients. I was sitting there in theatre trying to get control, and they were venous, these are venous bleeds. And they're very difficult to control. They're thin-walled and they bleed like hell. And eventually got control. But what I'm trying to illustrate is that, yes, place of fear. You need to be in control. Don't go on to the next step until you fully control this one step. Know that what you're doing is according to what the teaching says. Also know that you have to make decisions that you don't contribute to the problem. Contribute to the solution, but not to the problem. Do the minimum required. Remember the words of our pioneering neurosurgeon, Harvey Cushing. Cushing was the first neurosurgeon. And his words to all subsequent generations of neurosurgeons was, beware you tread where God never meant you to go. We're at a disadvantage the moment we put the knife to the skin. We're already at a disadvantage. If you don't play by the rules, you're going to get clubbed and your patient's at risk. Long answer. Yep.
Is there any application for P&I in professional sports?
Very much so. So let me tell you who implemented it, since you're asking. The All Black rugby team. So in 2007, they had a disaster in France. And they went back to New Zealand, outcasts, with their tails between their legs, ready to be hung from the nearest kangaroo tree. And they decided, they went into a deep soul search, and they tried to work out what is required. We've got great players, great talent. We've got pretty good strategies. Why did we lose? And they went into this mind state story. And they got a neurophysiologist. So there was a real neurophysiologist attached to the coaching group of the All Blacks team. And they decided that they needed, this is real, I've written an article on this. It's not in the book. I've written an article on this on LinkedIn because I was so amazed when I read the background to what they had done. The neurophysiologist had said, the team that will win will be the team that can think in an extreme situation. In other words, retain prefrontal cortex and retain reasoning in the heat of the moment, and if you're going into hopeless helplessness, in other words, the score's against you. If you can retain meaning and purpose with prefrontal cortex reasoning in the face of everything going against you, you've got the edge. And the other thing is, be individual, but be part of the group. It's all for one and one for all. And what they actually did was they had a rotation. That after each match, one or two guys had to clean up the change room for the team. Then they changed the haka. Do you know that the haka is different? It's from 2007. The haka is completely different. They had it compiled for the All Black rugby team. And in the haka is the neurophysiological principles. It was embedded in the actual acting out, and the wording and the rhythm of the haka was a neurophysiological based approach. So the guys under stress will be for the team. The team will gain strength from its group, belonging to the group, trust, empathy, collectiveness. It's all oxytocin stuff, dopamine stuff, feel-good stuff, maintains prefrontal cortex thinking. minimizes reactive behavior, which is amygdala. If you can keep the amygdala quiet, don't react with aggression, don't react with panic, don't keep the amygdala quiet by maintaining dopamine, the enjoyment of the game and the reasoning in the face of hopeless helplessness and the need to think in the heat of the moment, you got the edge. And no one has come close to that team. And that is what was built up after 2007, very much a neurophysiological application. Are we serving midnight snacks?
Don't disappear. Okay, can we get something else? A big thank you to Dr. Ian Weinberg. That was fantastic. Covered a myriad of things. And he didn't mention his fantastic explanation of Albert Einstein's theory of relativity. Excuse me. E equals mc squared. And the way he explains it in the book, you don't have to be a brain surgeon to understand it. And really, I can't emphasize it. It's a good read. It's a comfortable read, but it also is quite technical, but nothing you can't cope with. And also a nice human story to it as well. Dr. Weinberg, we're going to give you a little gift, but just the one gift is a little coffee mug. And this coffee mug, when you heat it up, it gives you the best logo in the world. So don't forget it. Enjoy your coffee, and thank you once again. Okay, just... just quickly, guys, I know it's, you wanting to get up and have a drink. The September conference, the Millennial Chiropractor, an integrated approach to neuromusculoskeletal healthcare. Exactly what Dr. Weinberg was talking about, the integration of all the disciplines to the benefit of the patient. We've got a great lineup. First up will be Dr. Josip Kacik, also known as Dr. Chuck. And he is our hip guru, and he does both non-invasive surgical interventions for labral and cam lesions in the hip, and also he does your fantastic anterior approach to hip replacement surgery. And then we'll also have, thoracic outlet syndrome is also quite a confusing thing. You see it in practice. You can also think it's radiculopathy from the cervical spine, and it is often misdiagnosed, or put it this way, more so than you realize. This is according to Dr. Ariel Ale, and he's in practice in Waterfall in Midrand, and he's going to be covering the modern-day arthroscopic decompression of thoracic outlet. And I've had quite a few patients being treated by him arthroscopically, which is very interesting because typically they used to go in through the axilla or posteriorly near the scapula, which is major surgery and quite dangerous. So a very interesting one to also to listen to. We're also going to have something a little bit different. We're going to have Dr. Sean McCoy. He's a PhD in marketing and branding. He's the CEO of HKLM. In fact, do a lot of work for Nedbank. And he's going to give us something about you, the practitioner is the brand, and also our collective entity as an association, as a brand, and ways to actually grow our profession. And that will be a very interesting lecture. And then we're also getting Dr. Margaret Serin and Dr. Kay Highland, who are both contributors to Yoakum and Rowe with all the editions. And they'll be covering radiology for us. And yeah, anything from straight x-rays to MRI analysis, and it's something that there's always new stuff to learn. And so a very good one. And then also Dr. Tom Hyde, whom I don't think he needs any introduction in sports injuries, and lots of techniques he can cover. And the nice thing about this Congress is if you are out of Johannesburg, we don't want you to come, because we are going to fill this auditorium up, but at the same time we're going to take the conference to the practitioner wherever you are. We're going to be live streaming it. It's going to be on a crowdcast, a little bit different to YouTube, and you are going to be able to, instead of having an audience of this auditorium here at Nedbank is going to take 231 people, we will increase this audience to more than double that. And so if you're out of town, we want you to please support the initiative. If you're obviously coming up to Johannesburg, we're going to have lots of prizes to give out. We've got great sponsorships, anything from having a drive in a nice car for a day or two, to winning an expensive mountain bike, to weekend away at the Piedmont resort, and the list goes on. We're working on some great sponsorships, and you will be rewarded if you come and support us here. And there will also be some prizes to people live streaming, and we also will be giving them CPD accreditation. So there is a way forward with conferences. Like I say, if you're out of town, please support it, because it's going to happen when the conference is not in Johannesburg, and the young practitioner or the old one who's got himself into financial debt can't always afford to go down to a conference. The financial implications are huge. Giving up time in your practice to actually go down to a conference can be thousands of rands, and so we need to also, rather than have you miss out on the pool of knowledge, we feel that you need to actually gain, and that way we can grow our profession, and not just have a conference and the lecturers like Dr. Weinberg being confined just to people who can afford to go to conference. So please, the prices for the conference this year, I can't give you an exact figure, but I can tell you now it's going to be lower than you've paid in the past 5 years as a member of CASA. If you're a non-member, it's going to be double. Okay. So you better, those who are not members, there's a reason to be a member of CASA. And obviously that will also be applicable to live streaming. So I think that's about it. Dr. Brad Sandler just wants to say a couple of words, and thank you very much for supporting us tonight. It was a great turnout.
Hi guys, I'll literally be it's bad for the solar panels at the top. They're just going to put something onto the screen quickly. I just want to chat for 2 minutes on behalf of Cairo Sports South Africa. I know all of us are always looking for a different tool for our briefcase. Next month, 12th, 13th of May, we bring out a factor course. A little bit about factor, instrument-assisted soft tissue mobilization and manipulation. Guys have heard about Graston, rock blades, smart tools. Factor was developed by Tom Hyde, now taken over by Todd Riddle, top chiropractor in the USA. We're bringing him out next month to come and speak and to teach us. It's a 2-day course, CPD accredited. Awesome course just to learn about how to use the tools, how to work the muscles, how to work the fascia, all that type of stuff. It's going to be hosted at UJ. Please, guys, we're limited to space. I think there are 15 slots left. I can't pull in any favors. I always get phone calls from people, please, I'm not handling, or CARASport's not handling the registration or anything like that. It's an online link in order to sign up, all that type of stuff. It's being done in the US. I'm going to get the CASA guys to send, it's mainly gone out to CARASport members, but I'm going to get the CASA guys to send it out to all CASA members. Guys, please register online ASAP if you want to be part of it. Okay, it's next month, 12th to 13th of May, and that whole brochure will come in the mail, so you'll all learn about it. Okay, thank you.
Sorry, guys. Those people who put their business cards in the bowl, we are going to take a lucky draw on a Nedbank-sponsored travel bag. So when you do travel down for a conference, you'll be able to put your clothes in. So, Lise, I'm going to take you. Where is it? All right. So that's what you can do. Very convenient to have. So, Lisa.
Dr. Sarah Somerville.
Yeah. Safe travels. All right, cool. Yeah.
Sorry, guys. One more thing from CARASport. I got a message from Dr. Jaden Mays. They are hosting first aid courses that are happening on the 28th of April and the 5th of May. If you have any questions, you can contact Jaden Mays on drmays@morningsidechiro.co.za. It's a prerequisite to have your BLS, so if yours has expired, it expires every 2 years, you can contact him and you can do your course. Great. Thanks. It's a pleasure. No? The meeting's closed.